today to our CPAN CME presentation, Hidden in Plain Sight, Recognizing and Treating Eating Disorders in Your Office. My name is Laura Young. I am the program manager for the Northeast Texas CPAN hub here at UT Health Science Center in Tyler. We are excited to be able to present this educational session to you, and hope over the next hour you gain some great knowledge in the area of recognizing and treating those eating disorders, so that as you're working with your young patients in your office, you have you feel like you have a better place to stand in that basic knowledge. I have with me today Melody Phillips and Sarah Upson, who are actually local in our Tyler area. These ladies are considered some experts in their field, which is why we reached out to them and asked them to join us today for this presentation. I'm going to have both Melody and Sarah introduce themselves here in just 1 second. I do want to remind you that we are recording this session today. It will be available on our CPAN YouTube channel no later than tomorrow afternoon for you to view again if you need to, or if you know somebody who would like to watch this video. Once it is posted, or once the session is over today, unfortunately, you're not eligible for the CMEs. It's just the way it is. My apologies for that, but you can access it to watch it as much as you'd like going forward. So Melody, I'll start with you, and then Sarah, and then y'all can let me know when I need to change screens for you here.
Okay, sounds great. First of all, I just want to say thank you so much for having us. I know we're both really excited to be here, and we really appreciate your dedication to learning about the treatment of eating disorders. We are both highly passionate about this subject, and so we just really appreciate your presence. My name is Melody Phillips. I'm a licensed professional counselor supervisor, a certified perinatal mental health provider, and a certified eating disorder specialist. I'm the owner and a therapist at Maternal Mental Health of East Texas. There I really specialize in the overlap between motherhood and pregnancy and eating disorders, disordered eating, and body image issues. I am also the clinical supervisor with East Texas Eating Disorder Specialists here in Tyler.
Thanks, Melody. My name is Sarah Upson, and I'm really glad to be here today too with Melody, and just appreciate the opportunity to speak about eating disorders, something that I know we're both very passionate about. And so a little bit about myself: I'm a registered dietitian. I hold a master's degree in exercise physiology. I'm a certified eating disorder specialist and also a supervisor to provide supervision to other clinicians within the field. I'm the owner of My Signature Nutrition, where I offer outpatient nutrition education and counseling, specializing in the treatment of eating disorders and disordered eating and the broad spectrum of disordered eating.
So before we kind of launch into the objectives, I did notice there was a little bubble in the chat. And so definitely feel free to post questions, raise your hand. I probably am not going to stop. That way I can stay concise with the information that I want to give, because we only have an hour, and Sarah and I both could talk about this for hours. But we have reserved 10 minutes or so at the end for questions. So we'll definitely go back and try to address any questions that you have. You post in the chat, and then also feel free to, at the end, unmute yourself and just hop in and ask a question. So Laura, if you will go ahead and advance us, I will run over the objectives, and then we'll just get started. So at the conclusion of this presentation, participants will be able to identify eating disorders, disordered eating, and problematic dieting behaviors in children and in adolescents. You'll be able to explain medical complications of eating disorders, including diagnostic lab work to monitor eating disorder treatment, and then also make appropriate referral recommendations for patients with eating disorder and disordered eating at various levels of care. And so we have some referrals that are local, and then we have some referrals that are in Texas, and some that are national. And you can advance the slide, Laura. So what counts as an eating disorder? I'm not going to necessarily run through all of these slides, but we did just want to give you an overview. These are some of the eating disorders that are listed in the DSM-5, which is the Diagnostic and Statistical Manual that therapists use, clinicians really use to diagnose a variety of mental illnesses. So one thing I want to kind of touch on is the EDNOS-OSFED. So if you see, we put some asterisks there. You may be more familiar with, generally speaking, with anorexia nervosa, bulimia, a binge eating disorder, maybe even ARFID, and some of the others that we've listed. But this other category, what that EDNOS stands for is eating disorder not otherwise specified / otherwise specified feeding and eating disorder. The reason we put those asterisks is that this is the category where honestly most of our clients, patients fall into. A lot of people do not meet full criteria for example, anorexia nervosa. So they may have one or two components that are missing to be able to meet that full diagnostic criteria. So we would put them in this EDNOS and OSFED category. And we also put, Sarah mentioned disordered eating. We'll talk a little bit more about what that actually is. And so we put disordered eating in people that may not have a full-blown clinical eating disorder, but definitely have problematic food and the accompanying body image issues that go along with that. So most of the time, well, I'll kind of launch into a little bit how that EDNOS-OSFED category kind of can show up in your office and make things a little bit confusing. So if you will advance to the next slide. So here's some eating disorder statistics. And we wanted to give this to y'all. I'm not going to necessarily run through everything because I know that y'all can read, but we wanted to let y'all know and have some tangible statistics for how prominent eating disorders are. The reason that this is so important for us to share is that eating disorders are not something that we often recognize. And I say that from a therapeutic lens. I know Sarah was my introduction into the eating disorder treatment world, and I had no training. I had just little awareness of what an eating disorder was and why it was important. And I saw that a few years ago. I was at a social function, and I just happened to be talking to another therapist in town who I'd never met before. And we were sharing like where we worked and how many hours we worked and, just different things along those lines. And then we started talking about specialties. And when I mentioned that I was in private practice and I was working full time at the time, and I just specialized strictly in eating disorders, she was taken aback by that. She couldn't, what she actually said to me is, I can't believe you have enough people to fill a private practice. And I was like, oh my goodness, like I have more than enough people. I don't have enough room for all the people that are calling me. And so that just shows in kind of all areas how we overlook people with eating disorders just because we're not aware. And so I will mention, if you look at just those statistics, 1 in 5 women struggle, 13 million people binge eat, 10 million women battle with anorexia and bulimia, 1 million men battle with anorexia or bulimia. I want to note on the men that we actually think that number is underrepresented. We think that, well, we know that people tend to struggle in reporting eating disorders, but especially for men, there's even more of a stigma wrapped around their food and body pieces. And so we actually think that number is much, much higher, which means it's something that we all need to be collectively learning about and learning how to recognize. So if you will move on to the next slide, Laura. So here are some statistics, particularly for children and adolescents. Once again, I'm not going to run over them, but you can read through them while I'm talking. What you see here is that young children, as young as 9 and 10 years old, are really starting to develop this preoccupation with food and their body. They're really becoming hyper-focused on weight and health in an unhealthy way. And so we're seeing eating disorders and disordered eating develop younger and younger as we're seeing younger and younger children beginning to diet. So I'll kind of address that a little bit, but one piece that often shocks a lot of people, there's actually a treatment center in Seattle that treats children as young as 5 years old. And so we're just seeing that prevalence show up younger and younger. So that's one of the reasons why I personally, and I think I can speak for Sarah, we feel so appreciative that y'all are here. Another piece is that y'all know the doctor's office is a go-to, and so parents really trust you, and so being able to learn and recognize you're doing a huge service to your patients and their families. So Laura, if you will move on. So what causes an eating disorder? We look at it from a biopsychosocial lens. So as you can see, we kind of break it down. And what this is that we know that there are certain traits, there are certain pieces that are present and that predispose someone to an eating disorder. So biologically, we know that there are certain genetic commonalities, neurotransmission, transmitter commonalities, physical changes. We know that food restriction, which is dieting, can predispose us biologically to developing an eating disorder. And one piece that I will go ahead and say is that dieting is the #1 predictor for the development of a clinical eating disorder. And so that's something that really to pay attention to and hold. The other piece is psychologically. We know that certain stressors are often present in people that have an eating disorder. Statistically, they say that 60 to 80%, well, in the past, they've said 60 to 80% of people with an eating disorder have some type of trauma. More research is coming out that really supports that statistic could be 80 to 100%. And trauma is not always the big T trauma, things like assaults or abuse or natural disasters. It can be little trauma, little T's is what we call them in the therapy world, and not necessarily that they're less important, but maybe they're less obvious. So things like bullying, emotional and verbal abuse, things like food insecurity, not having access to food, poverty, different stressors along those lines. We know that people with eating disorders have limited coping skills. A lot of times eating behaviors can be a way to cope with these difficult emotions around these certain stressors that they have. Self-esteem and self-evaluation is typically pretty low in people that struggle with an eating disorder. And so that's a commonality that we definitely see. We also see certain personality traits and certain cognitive styles in the given eating disorder. So we know, for example, people with anorexia nervosa, the restricting type, tend to be high achievers, and they also tend to be highly avoidant of risk, tend to be pretty psychologically rigid. And so we kind of can see these things. And so even if I have someone who approaches me that may not be feeling like they have an eating disorder, they need to address it. If I'm hearing these pieces, then that typically raises my awareness that, hey, maybe I need to do a little more assessment. And then this society piece, there's cultural factors that are at play. You may have heard a term called diet culture. And I know that's something that I talk about frequently in my sessions. And that's just the culture that we live in that's really ingrained in kind of all these different aspects of our life. It really promotes kind of food restriction. It promotes what we call the thin ideal, and this kind of obsession with health as defined by being thin or fit, and only kind of fitting into these rigid categories. We also see a pressure to fit in from friends and from family, and people that suffer from an eating disorder. And so we kind of see these different factors, these biological, psychological, and social factors that predispose someone to an eating disorder. And then there's typically, I use the term, there's like, it's kind of like perfect storm. Then there's like a precipitating factor that can kind of trigger that eating disorder to really develop and kind of flourish. Oftentimes that is dieting. Sometimes it can be moving off to college. It can be having a baby, it can be a parent's divorce, moving, homes, a parent going to prison, big kind of pieces like that. And it's not always have to be a big event, but those are typically things that kind of tip the scales a little bit, and we begin to see that development. And on that note, I do think it's important to mention most people that I work with do not have an awareness of when their eating disorder started. And so I think it's really important. Clinically, I don't focus on trying to help someone understand exactly when their eating disorder started, unless that seems to be a really high need for them. And then often I want to lean into that and I want to find out, okay, so why is that so important? And how does that inform and affect your recovery? So we kind of look at it holistically and just know that people often don't know exactly when it is. And I will say, I have never worked with anyone who has said, I wanted to develop an eating disorder. I've heard that comment from people just in passing, but I've never worked with anyone that was their goal, that they wanted to develop these behaviors. So, Laura, you can move on to the next slide. So the Academy for Eating Disorders is a resource that we have listed. It's a wonderful organization and one of my favorite resources for really helping educate licensed professional counselors that I work with, and my clients is talking about the 9 truths about eating disorders. And I'll run through these pretty quickly just for time's sake. But the first one is that many people with eating disorders look healthy, yet they may be extremely ill. And this is really challenging some of our diet culture mentality that thin/fit people are always healthy. People that live in a thinner body are always healthier than someone who lives in a larger body. And that's just not always true. I've had clients that live in very thin bodies and have been very, very sick. And that we base that off of all these different pieces, their medical lab work, as well as just their psychological and emotional well-being. And then the vice versa, I've had people that live in larger bodies that actually have great lab values. They have pretty healthy relationships and healthy mental, emotional, and mental health. I think years ago, we blamed families for a lot, and we used to blame the development of eating disorders on families. And so one of the things that we know to be true is that families are not to blame. Once again, that goes back to that biopsychosocial model. And that families can be the patients' and providers' best allies in treatment. So they can actually be very, very supportive. And it is important to include family in the treatment process in some form or fashion. An eating disorder diagnosis is a health crisis that disrupts personal and family functioning. And Sarah will go into a little bit more about the health crisis aspect of it. But I think that language is really important for us to understand the gravity of eating disorders and how much they deserve our attention. Eating disorders are not a choice, but they are serious biologically influenced illnesses. I can't tell you how many times I have had a parent or someone sitting in my office that says, I wish you would just eat a cheeseburger. And that is just, it's not that easy. There's a lot of layers that go into it that are outside of our patients and our clients' control. So the eating disorder itself is not a choice, but we do talk about how recovery is a choice. And that's the last point that I'll talk about a little bit more. Eating disorders do not discriminate. So they affect people of all genders, ages, races, ethnicities, body shapes and weights, sexual orientations, and socioeconomic statuses. I think there's a stigma that eating disorders are for white, wealthy, adolescent females, and that's just not true. We know we can delve more into statistics for that to really show that eating disorders don't discriminate and anyone can suffer from an eating disorder. Eating disorders carry an increased risk for both suicide and medical complications. And we'll talk a little bit about the increased mortality rate or the mortality rate with eating disorders in a minute. Genes and environment play an important role in the development of eating disorders, right? Going back to that psychosocial model, that biopsychosocial model. There's actually some interesting initiatives, and I can't remember the full acronym, but there's some genes initiatives that they're doing around eating disorders. I think it's ED. I can't remember. But what they're doing is they're studying the role of genetics in eating disorders. They're really trying to understand that a little bit more, not because we think that genes predict the development of an eating disorder or recovery from an eating disorder, but we do want to understand more of what role do they play. And so that kind of leads into the next point, that genes alone do not predict who will develop an eating disorder, right? Going back to that model. And then the last point, full recovery from an eating disorder is possible. And this is a big piece, because for a lot of people, they feel like it's not possible. And so once again, we go back to the eating disorder itself is not a choice, but recovery is a choice. And so we want to, as a treatment team, Sarah and I particularly working together with physicians and with psychiatrists, we want to really support how can you engage in your recovery fully. One of the key pieces, and another piece why I think Sarah and I feel so grateful that you're here, is that early detection and intervention is absolutely key in helping someone recover sooner rather than later from their eating disorder. I actually had a conversation with a client last week who was kind of really working through when she started to notice and remember first thoughts around food and her body. And one of the questions she point blank asked me is, she said, why didn't anyone notice? Why didn't the therapist I was going to and the doctors that I went, why didn't they know that this was a problem? And, I used my own education process through this, and we just didn't, I didn't know. There were people that I saw way back when that I had no idea were suffering from an eating disorder, even though it was sitting right there in front of me. I just didn't know what to look for. So once again, I just am so, so appreciative that y'all are here and willing to learn something new, because that is key for your patients and for their families. So Laura, will you advance to the next slide? Okay. So there, as I mentioned, I've had eating disorders sitting right in front of me. They're easy to miss when they're in plain sight. This is going back to that first slide over the diagnostic criteria, that many patients don't meet full criteria. So we often have stigmas in our heads about what an eating disorder looks like, either behaviorally or presentation physically in the person who has the eating disorder. And a lot of our clients do not meet that, whether it's in our head or even in the DSM. And so that can make it very hard to see and to be able to diagnose. Traumatic weight changes, especially weight loss, are accepted as desired in our culture. So generally speaking, most of the time, weight loss, whether it's a small amount of weight loss or a large amount of weight loss, is kind of deemed as this positive, and people are really praised and encouraged to lose weight. And then the vice versa, weight gain is almost always seen as something negative. And really, we want to dig into that. We want to understand what's going on in either situation with behaviors around that. And we want to pay attention to the whole person and not just their weight. Many disordered behaviors around food and around their bodies appear normal and good compared with societal norms. This goes back to diet culture and just dieting behaviors, that a lot of eating disorder behaviors and dieting behaviors are the same. And so a lot of times what we're praising can be an eating disorder. And so we have to be really, really careful about commenting on other people's food and making recommendations and things along those lines. Our misconceptions around eating disorders and who suffers from an eating disorder can make it hard to see them when they're sitting in front of us. And from the medical component, medical complications of eating disorders and malnutrition present as common medical complaints. And Sarah will launch more into that. But that can make it really hard, because sometimes I've been working with someone who is really working with their medical team to try and treat a certain complaint or symptom. And really it's because of the malnutrition and the eating disorder. So what the treatments that have been happening aren't really effective because we're kind of missing what's really going on there. And then this last point really addresses some of our misconceptions. Most people with an eating disorder live in an average size or a larger size body and do not present as emaciated. I think a lot of times there are three main images that are conjured up when I say that I work with eating disorders. People tend to think of someone who is really emaciated and bones protruding, things along those lines, someone who doesn't eat like at all. And then the other piece is someone who purges through self-induced vomiting. And then the other piece is someone who is just binging on a variety of snack foods and fast foods and kind of these foods that our culture demonizes. And so we can miss them because we have these images that aren't fully accurate of someone who may suffer from an eating disorder and what it looks like. So Laura, if you will move on to the next slide. As I mentioned, eating disorders are serious. They have the second highest mortality rate, second only to the opioid epidemic. And that is a recent shift. For a long time, they've had the highest mortality rate. And this is, as I mentioned earlier, this is due to suicide and medical complications. Half of the deaths are related to suicide. So that means the other big portion are due to medical complications from malnutrition. And so that's why they are so important, because they can be silent, but very, very deadly. And then the last piece, which Sarah, once again, will launch more into this, eating disorders impact every organ system. And so we have to pay attention to them because they affect not only every organ system biologically, but also every system about all of who we are. So we have to give them the attention that they're due. So the next question is, when should I worry? And Laura, if you will move on to the next slide, that will address it. As soon as you suspect an eating disorder, sorry, typo there. So once again, it goes back to early diagnosis, access, and intervention is vitally important. So if you have any inclination that someone may be suffering from an eating disorder, referral, refer to a therapist, a dietitian that are trained in eating disorders. That training is really critical and really important. And once again, we'll give y'all some resources and some referrals. That way you have that in your back pocket. Eating disorders prevent in a variety of ways. So this can make the referral and the treatment piece a little tricky. Kids and parents are often resistant to the diagnosis and the treatment. One of the therapeutic goals that I focus on is really helping the family and the person that I'm working with differentiate from the eating disorder. A lot of times they'll feel like the eating disorder is just who they are. And so really working to separate, like, who is your authentic, true self and who is the eating disorder self. But that can make it a little tricky to encourage someone to get the appropriate level of treatment. And then once again, eating disorders can occur without what we consider obvious signs or symptoms. They can be kind of subtle and be kind of mixed in. And Sarah will go into the medical piece of that a little bit more for you all. So Laura, if you will advance to the next slide. And Sarah, I will hand this over to you now.
Thank you, Melody. I think the biggest take-home message from this point is that eating disorders are very serious and they're often normalized within our culture, and they don't typically present as a typical eating disorder that you would expect with that DSM diagnosis that you may be familiar with. And so the question becomes, what do you look for in your clinical practice? And starting with just some general things to look for. First would be weight changes, and particularly in adolescents, we're looking at weight loss, weight gain, fluctuations, and going back to the growth curve. And just as a reminder, in adolescence, like, we expect growth along that curve, and we are not comparing to other children, but just the individual child's growth along that curve and looking for a normal pattern of growth for that child. And so when we see someone falling off of their growth curve, that is where we want to be concerned. And I think a very tricky part here is when somebody maybe is growing normally along the 90th percentile, and then all of a sudden they may lose weight down to, let's say, the 70th, 75th percentile. And oftentimes that child receives significant praise. I've even had clients come in who their doctor praised them. My pediatrician said, good job on losing weight. And nobody ever stopped to ask them, well, how did you lose weight? And oftentimes what I hear then is, oh, they were vomiting their food, self-induced vomiting. They were excessively exercising. They were engaging in behaviors that were extremely harmful, but nobody ever asked them. And so they were just praised for using these eating disorder behaviors. And so always being mindful, like a red flag coming up when you start to see weight changes. And if I could encourage one thing, and I know it's really difficult, would be to never praise weight loss. And that may seem really strange and backwards, but you never know what you might be praising. And so if someone is coming in, I would just encourage, be curious. Were you trying to lose weight? What kind of behaviors were you using? And oftentimes patients that present with an eating disorder are very savvy and they will come in with information. I even had one client, her mother took her to see a doctor because she was concerned about weight loss. And the client had done research ahead of time before she went to the physician and basically lied her way out of it. And the physician agreed with her and was like, yeah, this isn't anything that is concerning. And so you really have to be on your A game, ready to look at all of the things that are playing into the behaviors that you're seeing. And I would say if you're questioning it, that would be a time for referral, just to let the specialist come through and really dig deeper where you may not have the time to do that. And then we can work as a team and come back to you and let you know our findings. And so again, people are often very savvy. They end up looking very rigid around their eating patterns, rigid exercise patterns. You may hear those buzzwords like healthy eating, clean eating, just cutting out processed foods. And some of those are actually telltale signs for the start of an eating disorder. And that also gets a little messy because sometimes we have to check our own biases towards our own internal beliefs about foods and body and weight and the impact that they may have on the patients that you see. Another thing to look for in your practice is cold intolerance. And I know clinics are typically kept very cold anyways, but clients coming in large jackets, hoodies, layers of clothing, maybe taking them off when they go to weigh because they don't want that additional weight on the number on the scale, and then they pile them back on, changes, but maybe they've come in like normally dressed and now all of a sudden they are looking very different in the clothing that they're choosing. Also, we tend to see the acrocyanosis, the bluing, and the fingernails and the toes and the extremities. It can be quite extensive. And then along with that, we see weakness, fatigue, dizziness, fainting, that rigid focus and thinking. And I think really remembering that the behaviors in our culture are accepted as normal. That's that diet culture that Melody talked about. And so along with that, then we often see resistance and seeking help because what they're doing is getting praise. And for many people, that praise holds a lot of worth for them within that. And the difficulty too is oftentimes labs present as normal. And I think I have that coming up, so I won't dive into that just yet. But I've even seen a client with a BMI of 13 whose labs look totally fine. And then what happens is they come back and they say, well, my doctor said my labs are fine. So nothing is wrong here, when in reality, we have to look at the whole picture. And so moving into some other areas, Laura, if you'll advance the slide, please. When we look at ear, nose, and throat, sometimes what we'll see is more of that oral trauma or lacerations. We can often see dental erosions and cavities. Sometimes even the teeth begin to crumble and break apart, and not just in bulimia. We see that in anorexia too, where there's extensive restricting behaviors and just the loss and atrophy that is really systemic within the body. Within dermatology, often we'll see that fine hair growth or lanugo. Hair loss is a telltale symptom. Clients will often say, my hair is falling out. I'm losing clumps of hair in the shower and on my pillow. Oftentimes you see that dry, brittle hair, nails, and skin. I have this picture of biotin here because 9 times out of 10, that's anecdotal. I have a client come in for assessment. When I ask about any vitamins or minerals they take, they are always taking biotin because they have dry hair, dry skin, and brittle nails. And that is a nutrition problem, not something else going on within the body. You might also see bruises on the bony extremities, and then Russell sign, which is the scarring on the back of the hand. And I will say that is so rare. I don't know if I've ever seen that in clinical practice. And so not relying on that as something that you see, but asking. And oftentimes patients are very honest, but you have to ask the right questions, and it tends to have to be very direct. Have you ever made yourself sick? Do you ever make yourself sick after eating? And oftentimes they will tell you the truth. Next slide, please, Laura. And within cardio, this is often a place where we can see some clinical information come into play. And so when we're looking at vitals, and what you might hear from clients is they'll say, I have chest pain, my heart is racing, I have dizziness with standing or in the shower. And this is one place where we can pick it up when we look at heart rate, when we look at blood pressure and orthostatic vitals. And I think something really important to remember that when you see someone come in with a low heart rate that is also low weight or has lost significant weight, it's really important to remember that that is not a healthy heart. That is somebody who has had significant atrophy and the heart has slowed its heart rate because it is conserving energy. It is a weak heart, but I can't tell you how many times clients will be praised and say, oh, you're just an athlete and you have an athletic heart and you're so healthy, when in reality, what we're seeing is indicative of a much more serious problem. And again, a side effect of the eating disorder is anosognosia, or the inability to recognize the severity of the problem. And so that is in the diagnostic criteria. So you often don't have someone come in and say, I'm really worried about my eating. What you see are the complaints and the physical symptoms that go along with that. And making sure that you're doing vitals with blood pressure, both sitting and standing, so we can get the orthostatic vitals, because often we see a big difference there. Okay, next slide, please. GI is also another place where we see a lot of complaints. In one research study looking at patients that were in a residential treatment center for an eating disorder, 99% of eating disorder patients experience some type of co-occurring functional gut disorder, constipation, bloating, gas, diarrhea, nausea, reflux, upset stomach, you name it, most people had it. And it's a key factor in that is the nutritional component. So when we are seeing these side effects, it is the impact of low nutrition, and holding that impact of low nutrition isn't just people who present in low weight bodies. When we look at the research, only 10% of people who have an eating disorder will present in that typical diagnostic factor. 90% appear normal or in an average to higher weight body. And so what happens though is we see these symptoms that are presenting and looking for those complaints so that you can know, oh, you're having some constipation, you've lost weight, you've got stomach pain. These are the number one complaints that people complain of. And it may be strange to think, oh, could this be an eating disorder? But then looking into, oh, well, walk me through what you're eating in a day, and holding your own beliefs about food, holding those in, but listening. Are they missing any food groups? Oftentimes you'll hear carbs are low, fats tend to be low, high intake of fruits and vegetables, and very lean proteins. Again, what our culture may say is a very healthy form of eating, but when we're considering a normal eating pattern for adolescents and really overall balanced eating, it tends to be pretty atypical. And so what we want to look for are the side effects in that rigid, good, bad thinking about food. And a benefit of treatment is almost every side effect or symptom that we're seeing of the eating disorder is treatable with nutrition restoration. And so these complaints can improve as nutrition improves. It just takes some time to get there. I think another thing to know with GI is that oftentimes we see high crossover. So somebody can have an initial presentation of a GI disorder, and then in an attempt to fix the GI disorder, they move into restricted eating patterns, and those restricted eating patterns can lead into an eating disorder, and then the eating disorder itself can lead back to more GI disorder. And so it becomes a very vicious cycle that can go round and round. All right, next slide, please, Laura. Next, we move into endocrine. Within endocrine, a lot of what we'll see will be hypoglycemia. And sometimes that presents as that shaky, weakness, sweating, nausea. And now some people will interpret that as hunger. Oh, I know I'm hungry when I'm shaky and I feel anxious, and not really identifying that actually that's a symptom of hypoglycemia, or it could be. And newer research coming out on eating disorders suggests that hypoglycemia could even be a cause of death, that sometimes we don't know physiologically, what is like the tipping point that leads to death within an eating disorder. And a new theory that has been projected recently is that the hypoglycemia is a significant factor in that. So it's something definitely to monitor for. To make it more complicated though, many clients function with hypoglycemia for a prolonged period of time, and their bodies adjust to low blood glucose levels. And so they can come into your office fully functional and appear and present normal. I've seen with blood sugars as low as 40, appearing normal, and that's just what they become used to and is their normal. And so then it's not something that you could easily identify. And so making sure, just as part of routine labs, you're checking for blood sugar. And oftentimes people would think diabetes, but also considering like, oh, are there any atypical eating patterns here? Is there any body preoccupation? What else could be going on that would be concerning? And then amenorrhea. Lack of a menstrual cycle, and somebody who has started a menstrual cycle should never be considered normal. I can't tell you how many times I hear that recently. I think it's become a trend on Instagram for some reason. And so just remembering that if you have somebody who has started a menstrual cycle and then they have lost their menstrual cycle, and it is accompanied by restriction, weight loss, changes in eating patterns, increased exercise, these could all be red flags for an eating disorder and something seriously to look into. And just a clinical reminder, when we look at the literature on eating disorders, birth control is not an appropriate treatment for amenorrhea, for hypothalamic amenorrhea. And what we really need is nutritional restoration and weight restoration to help. And a side note with that is that birth control does not protect against bone loss. This is often a reason I hear it given, is that, oh, it'll help with the osteopenia that often accompanies lack of a menstrual cycle, and it does not. Often what we see is it plays into that mentality of the individual is that, oh, I'm fine, nothing is wrong. Look, now I'm having a normal menstrual cycle. And in reality, it's still a serious problem. Bone fractures are common and not common. I have had clients. I had an 18-year-old client who stepped off a curb one time and broke her hip. I had another client who was out running and fell down and fractured her elbow. It is rare, but also not rare and at the same time. And so just knowing that osteopenia is a significant side effect from that. And unfortunately, it's hard one to get patients to care about because they feel like, I feel fine. This isn't impacting me. This is a risk like 40 years from now. And it's really hard to get buy-in on that. But the malnutrition causes these significant concerns that impact the time and also throughout life. Next slide, please, Laura. Next, moving into some of the neuropsychiatric concerns, I think knowing that comorbidity is the norm within an eating disorder. So the statistic is very high. I don't remember off the top of my head. 90% present with depression, anxiety, OCD. We can move into more clinical bipolar, schizophrenia, schizoaffective disorder. We tend to see significant crossover within comorbidity. With nutrition concerns, we often see poor concentration and memory loss. Clients will often say they're struggling in school and they can't concentrate and they read the same thing over and over, while at the same time will often end up performing academically the best they've ever performed. You know, my daughter got straight A's on her report card and she's just doing so well academically in school and in her sport. And what happens is we see a very narrowing of their world. And so whereas their world was quite broad with social events and engagements, within the eating disorders, those began to get cut out, and then they become hyper-focused on food, body, and then maybe one or two areas within their life. Academics and sport tend to be those areas, and oftentimes we see an increase in performance, which makes it harder to get buy-in that their eating patterns and body focus are problematic. Other common side effects, insomnia. We often see hypoglycemic drops at night that interrupt sleep with sleep waking and night sweats. Self-harm is often prominent, suicidal ideation, thoughts and or plan, as we often also see that suicide is often a factor in death from an eating disorder. Seizures, some people can be having hypoglycemic seizures, which can be common, and they can also be happening unknown to the patient. And then substance use and abuse co-occurring is also common.
Can I jump in here real quick, Sarah?
Yes.
So one thing I want to add is if you have a child or adolescent that one of the concerns that mom mentions or dad, that there's some self-harm or suicidal ideation thoughts or plan, is to just assess food behaviors and kind of going back to some of the things that Sarah had talked about, like what does eating look like? A simple way to start that conversation is to ask how many snacks do you have a day? How many meals do you have a day? Asking what time they eat. A very, very common behavior is someone will wake up in the morning and not eat until 2 or 3 o'clock in the afternoon. And sometimes that'll be just one meal. Another common piece is that people will eat, they will drink either hot beverages, coffee, tea, to stay full instead of eating. So I just think it's really important because we do see such a high overlap when any of those things present, that it's helpful just to ask those basic questions. And then if you have concerns, to give the appropriate referrals.
Thanks, Melody. Next slide, please. And so digging more into assessment, things that you would want to look for or document would be percent weight loss when somebody has lost weight. And sometimes that can be helpful for looking at somebody who is maybe like 80% of their previous weight, 75% are becoming very concerning. We also want to look at rate of weight loss over 6 months or longer. I had a client I just assessed last week, an adolescent male actually, and he had lost 30 pounds in 6 months. And he's like, that's not concerning. That's a normal rate of weight loss. And when in reality, that's actually very concerning. That's considered rapid weight loss. And remember that rapid weight loss at any given starting weight is concerning. So even if you see somebody in a higher weight body and they come in and they lose weight, trying to hold back the praise, not a place to praise because we don't know how they lost that weight. And it could really be some pretty dangerous disordered behaviors, and asking again, was this intentional? How did you lose weight? What were you doing? And trying to get what's going on behind that. I also think holding that not everyone loses weight. Some people can present with a very serious eating disorder and not have lost any weight at all. And sometimes they'll actually be the most restrictive patients that you'll see. Clinically, it doesn't make sense on paper why their body isn't losing weight. And for that patient, it just reinforces the need to restrict more and more and more. It becomes honestly a scientific mystery, in my opinion, on why their calories can be so low and how their weight does not change at all. And so really listening in, and what you see is just extreme thoughts, preoccupation, body thoughts, and just very high rigidity with food, intrusive thoughts. And oftentimes these patients have to go to a higher level of care and have such shame because their weight is not low enough per the eating disorder. And again, remembering that growth should be individualized and follow the own child's unique growth pattern and chart, not looking at the population, but the own child. We want to also look at heart rate and blood pressure. Heart rate near 40 is considered to be something that would trigger admission to a higher level of care. Blood pressure around 80/50 and orthostatic. So heart rate increasing by 20, increases in blood pressure by 10 to 20 millimeters of mercury would all be things that would be very concerning. That was with orthostatics. I can't remember if I said that. And then oftentimes, as I said, labs will appear normal. And so CBC, CBP, EKG recommended, and they can oftentimes come back very normal. And I usually try to prepare a patient for that. Hey, let's get labs done and just check where everything is at. I want you to know ahead of time, though, that oftentimes in the eating disorders, labs present as normal. So if you're expecting an atypical finding, that may not happen, but it doesn't mean your eating disorder isn't serious. And so we have to prepare them for that. Some things that you might see as low would be blood sugar levels. Potassium can sometimes be low. That's typically with somebody who is purging, and that can be something that is extremely dangerous and can lead to death. So watching for that one. Thyroid can sometimes be low or altered. Oftentimes it's euthyroid 6 syndrome, where thyroid may be different, but it's really looking more at the nutritional component that's impacting with that. Sodium can sometimes be altered, and honestly, that tends to be hydration status with clients drinking copious amounts of fluids. I even saw a case today of someone who drank 19 liters of water in just a couple hour period and ended up in the hospital. They ended up being fine, but just knowing that patients will do things that you may not even think of in attempts to modify weight or to lose weight. Nutritional intake, just asking some questions, looking for restriction of food groups, cutting out food groups, and then compensatory behaviors, which could be self-induced vomiting, skipping meals, laxatives, exercise that is, oh, I ate a donut, so I had to go exercise, looking for things that would be an attempts to make up for intake. And things that you could ask for too would be like, oh, could you miss a day of exercise? What would happen if you did miss exercise? And then also looking for behaviors around weighing. I had one client who was like, I went on vacation and I packed my scale with me in my suitcase to take on vacation, and was just rigidly weighing and couldn't stop. Also looking at menstrual history, family history, and then psychiatric history if eating disorders are a common occurrence in the family, or if there's any co-occurring depression, anxiety as well. Okay, let's keep going. I want to be mindful of the time so we can save some room for questions. So rinse or refer if you are suspecting an eating disorder at all, or even questioning, or even just kind of like, oh, that was strange. I don't fully know what happened there, I would recommend referring immediately, and we can always support you and help you with that diagnosis. In terms of a higher level of care, we're looking for less than 75% of BMI for age, although they may go to treatment without being underweight. They could be normal weight, or they could have had significant weight loss. And so weight isn't always a trigger. I one time sent a client to her pediatrician just for a medical assessment. She had already been accepted to a higher level of care at a residential level. And the pediatrician was like, well, you're not as bad as anybody else that I've seen. And so it's okay. And then what happens is the patient is very fused with, well, I don't need to go to treatment, when in reality, what we're seeing is a serious eating disorder. And so knowing weight is not always the deciding factor, and most patients present as normal. And so we need to shift off the weight and look at that whole picture. Hypoglycemia, electrolyte disturbance, we've talked about the vitals, acute medical complications and malnutrition, acute food refusal. I had one client who would throw her food in the trash can when her mom wasn't looking, dumping her smoothies down the sink, and just unresponsive to treatment, and then those comorbid complications. And so being on the lookout for that bigger picture. And if you're ever unsure, we can always help. We're available to case consult as well. And just knowing that sometimes it can come on pretty quickly. There is a young girl out in Longview, actually, who died a couple of years ago from her eating disorder. And she was in Children's Medical Center, not the eating disorder branch, but just plain Children's in Dallas. And her mom asked the physician point blank, does my daughter have an eating disorder? And the doctor said, no, this is just GI complications. And then she went home, and 2 weeks later, she died. And she was having fainting and syncope and potassium abnormalities. And so really being on the lookout that they're actually a lot more common than you think, and very dangerous. Okay, next slide, please. And then our treatment goals are really to address any of those co-occurring problems that are presenting in your office, both in medical stabilization, nutrition, return of normal psychosocial function and engagement in relationships, and then normalizing behaviors. And the thing to know is that a treatment team approach is the best practice approach. And so we want to be working as a treatment team, including a therapist, a dietitian, a doctor, oftentimes a psychiatrist, sometimes a dentist. Sometimes that team can grow pretty extensive to include a GI, a dermatology, endocrinology, and become quite a lengthy list of members on the treatment team, but wanting to make sure that we're addressing in that best practice approach. Okay, next slide.
Can I just add in super fast, and just also being, and this kind of plays in here, and making sure that your referrals have specific eating disorder training. That piece is really critical. I mentioned, and Sarah has mentioned, that it's been missed. I've had, before I had any training, and where I've missed it. And so that referring to, you may refer some people to someone for depression, but having separate referrals for people that struggle with an eating disorder that have that training is really critical.
Okay. I'm going to leave this list of referrals up here for you. I think maybe one to know about would be that small one on the right-hand side, the AED medical guide. This is a downloadable PDF that you can print out and just have available to you. They just came out with their 4th edition this year, and it has a list of labs to run. It has interpretation of those labs and just some good information to know, and is a great starting point. If you're curious, the books down here, Sick Enough by Dr. Jennifer Gaudiani and The Eating Disorders Guide to Medical Care and Complications by Dr. Mailer, are amazing resources. I'll just note that Dr. Gaudiani's reads more like a book. Dr. Mailer's reads more like a textbook. And so they're also good places to start as well.
Yeah, I was going to support Sick Enough. I think it's a great book, and I often recommend it to parents.
Okay. So I see that we have some questions over here. Quite a lengthy list of questions. And so
do you all want to just go ahead and start at the top, or you can skip mine if you want to, but there are some great questions in here. I'll let you go through them instead of reading them. I think it'll save a little time. And I'm going to need to put up the code for the CME so that those who have to jump for clinic can, but then we'd be here and available to answer questions as long as people have them. Is that okay with you?
Yes.
Yes. Okay, perfect.
Okay, so I'm just going to start at the top. How can we differentiate between someone of the awful eating habits of teens versus eating disorders? I would say as an eating disorder clinician, I would challenge your language on describing eating patterns of awful. I hear what you're saying, while at the same time want to challenge looking at a bigger picture. So when we're looking at somebody who has maybe patterns that are really unbalanced and not including all of those different food groups or eating in a consistent pattern, really kind of deciphering through what is driving the factor behind that. Is it preoccupation with weight and body, or is it video gaming, which actually we're seeing more and more treatment for that within eating disorder context, because the barrier to eating turns into an eating disorder. And so looking at the intention behind that, and sometimes it's presents very differently, but has a similar symptoms that you're viewing. Melody, would you add anything to that?
Yeah, I would add that's where the treatment team best practice comes into play. I think if you have questions, Sarah mentioned we're available to consult. And I do think that treatment team approach is so important, so that if you have questions, you can just bounce it off of someone. And I also think if you have any concern around food behaviors, making the referral is because of that early detection and intervention. I always tell people that are resistant to working like with Sarah, I will say, like, if she says to you, you don't have to come back, I'm fine with that, but you need to get an assessment. And so just maybe defaulting to, I'm going to make the referral and the recommendation if any kind of red flag comes up.
Thanks, Melody. The next is, can a lack of weight change also be a red flag? Yes, absolutely, especially around the teenage years when children are expected to be growing. I can't read the full text there. Oh, be gaining weight. Yes, so lack of weight gain is absolutely an indicator. So it would be kind of falling off of the growth curve. And it's absolutely a sign that they could be developing some of those dangerous patterns or habits. Next would be, could you provide us with resources for dietitians in the San Antonio area? I think I would refer you to IADEP, which is the International Association of Eating Disorder Professionals. They do have a treatment finder on their website, and I think that would be a good place to start. I also know that Eating Recovery Center, it's a treatment center, has an outpatient, I think it's intensive outpatient in the San Antonio area, and that might also be a place to start. So I don't know if they take Medicaid and CHIP, but they should have a social worker who can probably connect you to a resource that does.
There's also Central Texas Eating Disorder Specialists as a website. You can Google that, and they have a list of therapists, dietitians, I think a variety of providers that are trained.
Yes. Can you see clubbing with these disorders? Sometimes you will see it secondary to weight loss. And so that moves out of my wheelhouse of being, is that impacted by something else? But sometimes it will just be like the malnutrition, where you're seeing so many bony protuberances that it can appear as clubbing. So maybe I'll say that. Can you discuss orthorexia briefly? Yes, thank you for asking that, because orthorexia is not a diagnosis that's included in the DSM, but it is one that's really important, and I think one that in the future we'll see. So orthorexia, the definition is a fixation on healthy eating, and the problem is that it becomes obsessive, and it can interfere with both quality of life and overall health and well-being. And so we tend to see weight loss, we tend to see inability to engage in social activities, events, relationships, inability to go out to eat because of concerns about the food that is there, and it becomes very life preoccupying. And so I suspect in the future we'll see that in the DSM. But what I've seen is that on a world view and a global view, that trying to come up with a diagnosis that is consistent globally is that orthorexia is very much impacted by ethnic regions. And so it's hard to come up with a consistent definition because of how it changes globally on the area that the person presents in. Also, never praise weight loss. Can that be couched in clinical context? In primary peds, we're often encouraged to be motivational regarding obesity in children. Yes, I know it is a rock and a hard place. I would encourage to maybe praise the behavior once you know what is going on. So, oh, you were adding fruits and vegetables into your meals and you never had fruits and vegetables before. It sounds like you did a great job in including a new food. Oh, you are engaging in activity and are spending less time watching TV. Like praising the behavior when you know that behavior is not a concern driven by the eating disorder. And so I know that's a rock and a hard place and very tricky. Do you want to add anything, Melody, there?
Yeah, I was just thinking of a client that was actually referred by their pediatrician to one of my supervisees, and really presented as one of, kind of the living in a larger body, and really the concern that for the referral was that there was a pattern of binge eating, and really what we got to is really that restrictive piece, and that was really more of the problem. And the other piece just to note is that the restriction often, if not always, drives binging. And so really having to really being careful, and that's why we really talk about never praising weight loss, is because it's a tricky cycle. But I think Sarah did a great job. And like Sarah mentioned, it is a rock and a hard place. And this is where kind of therapeutically, we really get into some values and holistic health, and really pursuing that from a holistic perspective.
I think this is more a comment. Social media is promoting the extremes. Yes, I had to Google mukbangs because I honestly didn't know what that was. In my opinion, I would consider that to be binge eating. But yes, social media is definitely impactful, and I think the research on Facebook is like promoting body image concerns and eating disorders, and even that would be something to check in for. How much time are you spending on social media? Do you have concerns about your body? And I know you don't have a lot of time when you're with your patients and have a lot to get through. I even had one pediatrician tell me, I just don't have time to assess for eating disorders. And so sometimes having some very crafty questions that you can tap into can be helpful, and really sifting through when it's concerning. You want to add, Melody?
No, I think
Ladies, there was a question about repeating the organization again for the dietitian referrals, and I believe this provider is out of Texas, so can you help out again with that?
So the one that I mentioned was IADUP, which is the International Association of Eating Disorder Professionals. Their website has a resource or a referral finder, and that's, I think, where I would start.
Would one of you be able to type that into the chat? Then we can keep that long term.
Yes.
And that's something that our hubs can have as a resource and referral source.
It's also listed on the referral or resource page as well. So you can have it both places. Sarah, I want to jump to one of the comments about the limited resources here, and that they're mostly in the Dallas area. 100%. And this goes back to one of the conversations that I mentioned with the therapist of like, do you even have enough people to fill your practice? And I was, at the time, I was the only certified I wasn't certified, but I was the only eating disorder specialist. And I was like, well, I have too many people, and there's not enough people that are really, really trained in eating disorders that I feel confident referring to. And so I'm personally excited about the development of East Texas eating disorder specialists. I do have more therapists now to refer to that I'm confident that are trained in eating disorders. But we do have to, especially for a higher level of care, we do have to refer to Dallas, Houston, San Antonio, or Austin, and then even oftentimes out of state. I've had a lot of people go to treatment out of state because of our limited resources here. So it is an issue, and I kind of share a sense of maybe frustration with that. I wish that we had more variety of resources.
Ladies, would I be able to share your PowerPoint with those who are interested in having that information? That would be terrific. I appreciate that.
I would love to bring resources, maybe not myself, but give y'all some resources for referrals. That way you have that in your office. I know Sarah and our colleague, Celesta Smith, created a great checklist. So bringing kind of a variety of things. So if you're interested in that, I don't know, Laura, if there's a way. I'm sorry.
Yeah, if you would send those to us, actually, if you'd send them to Wiley, he and Elizabeth will get them into our resource library. And then if you're agreeable, we'll share those with our colleagues across the state of Texas. I suspect that those may be valuable to them as well. That way, if there are any other providers from outside our region, we would have those available.
Okay, that's wonderful.
Terrific. And then that way, providers across the state can reach out to their CPAN hubs and have that available.
Oh yeah, that'd be great. Yeah.
Terrific. Thank you.
Absolutely.
All righty. For those of you who would like the slides when you complete your evaluation, if you would put that in there, that would be great. And I'll ensure that we get those out to you. Ladies, it is 7 minutes after the hour. You were amazing. This is a topic that I think is extremely important. And we had, sometimes we have a lot of attendees and other times we don't have quite as many. But I may reach out in 6 or 8 months again and say, hey, can we redo this? Because this topic is so important. I think it's an area where we all need to know more. And you've been a blessing today. We appreciate your time. And thanks again.
Thank you so much for having us. I really appreciate y'all being here and inviting us to be a part.
Sure. Y'all take care. Have a great day.
You too.
Thank you.
Bye-bye.
Bye.